Okay, good evening, everyone, and welcome to the third lecture in the NSTS webinar series. Thank you so much to so many of you for joining us this evening. It's great to see such a huge number of you guys here. My name is Lawrence, I'm part of the education team, and tonight I'm very excited to be able to introduce Dr. Nicholas Ivin here, who'll be giving this evening's lecture on pre-op assessments. So just a bit of background about Nick. He graduated from Cambridge in 2018 and completed his foundation training at the West Suffolk Hospital. He now works as a junior clinical fellow in critical care at King's College Hospital, London, and has interests in patient safety and in-hospital resuscitation. We'll have time to answer questions at the end of the talk, but please just pop them in the Q&A and we're going to try and answer as many as we have time for at the end. Without further ado, I'll hand you over to Nick.
Thank you, Lawrence, for that introduction. Thank you to the National Surgical Teaching Society for setting up this platform. So I'd imagine most people tuning into this are either final year medical students or foundation years, so you'll be up and coming to your first sort of surgical foundation year jobs. I found that when I did mine, there were sort of two ways that people went about it. Either people were interested in surgery and managed to get into theatre, and then once they'd finished with the sort of the ward-based stuff, which is great. You can get into theatre as much as you like. It's a great experience, but very little is expected of you. And although it's great to see, you probably won't get to do too much to start with. However, even if you have no interest in surgery, all the stuff that happens outside the theatre that facilitates and optimise things to allow the surgery to go ahead, everyone will be dealing with this, and you'll probably have a lot expected of you even from day one. So this lecture is about preparing you to be really good and to facilitate the management of these surgical patients. So obviously the background to why this is important. So as the foundation years on a surgical team, you'll probably be the first people in the team to see a patient. So you are the first point of contact more often than not. You'll probably be, executing, most of this perioperative management. Your registrar might come down and see the patient, make a plan, but realistically, it's going to be you that's going to be, doing the dog's body work, executing that plan. It's a really important thing to get right because it really, really affects patient outcomes and patient experience. So, we all want, what's best for our patients, and getting this bit right is absolutely crucial to them having a good surgical outcome. And despite all of this, when we know that when junior doctors, do this for the first time, it's really daunting. They can feel really, really underprepared, as is evidenced by the quotes collected by the National Surgical Teaching Society from people who've been there and done it, and even those who've gone into surgical training. So this is a really, really important topic. So in terms of the actual objectives, what I'd like you to get out of this talk, I want it to be a really, really pragmatic overview of what your responsibilities are going to be when you're in these situations. I don't want to delve into the minutiae of each subject. I want this to give you, a really good idea of what you're going to be doing probably in the next, months to years. We're going to cover things like resuscitation of the unwell patient. We're going to cover symptom control. We're going to cover past history, issues about consent and capacity, and sort of perioperative management of co-morbidities. And I think more important than all of those individually is the approach to all of those. Because you're going to be landed with a lot of things to do with a patient in front of you, and what's most important is your approach to that patient, because that's going to keep you, as not stressed, and that's what's going to get the best things for our patients. This is going to be aimed at a sort of final year medical student level. I know there are probably a few F1s tuning in. If anything's too simplistic or if anything's a bit too advanced, I'm very happy to take questions at the end, like Lauren said. Most of this talk it'll focus on emergency scenarios. All of the same things are applicable to elective surgery scenarios, but realistically, emergency scenarios that's when the patients are most unwell. That's where you're the most stressed, and that's what I really want to prepare you for. Yeah, so let's begin. So a little scenario for you. So you're on call, you're the FY1 for surgery in a small hospital. Your SHO is elsewhere, your registrar and your consultant are in theatre, and A&E call you down to see this chap. So 74-year-old Ivin, hypertension, diabetes. He's had 2 days of abdominal pain and he's not opened his bowels for a week. He's hypotensive, he's tachycardic, he's pyrexial, he's tachypneic, and he's got low SATs. His HP is a little bit lower than normal. His lactate is 8, and there's evidence of free air and fluid on his CT scan. Your consultant very helpfully says, get him ready for theatre, and then hangs up. Now, I want you each to just take about 30 seconds and just think about how you are going to approach this scenario. What do you have to do now to make sure that this guy is ready to go to theatre? What things do you have to optimise? What things do you have to consider? What treatments do you have to give? And again, more importantly, what's your approach going to be? In what order are you going to do things in? Oh, sorry, I should have mentioned, don't post things in the chat when I'm asking questions. There will be a few clinical scenarios like this. Just make a little note of yourself, for yourself, of what you would do and what your approach would be. And then we can talk through it, and you can compare what your answer is to the approach that we would do. Okay, so again, just try and have an approach to the patient and just consider it what the first thing you'd do would be. Now, the first thing I would do is resuscitation. At the end of the day, you've got an unwell patient in front of you, and your first action should be to try and stabilize that patient, before you do anything else, really. At the start of each section, I'm going to take a minute just to explain exactly what your responsibilities as FYs are going to be with regard to each section. So in terms of the resuscitation, A&E in this scenario have probably already started. Your responsibilities are going to be to take over that resuscitation and review results. One of the most important things is you're going to be monitoring the response to every intervention you give. If you give an intervention and the patient gets better, brilliant, you've done your job. If you give an intervention and they don't get better, that either means, if they're not improving with, simple interventions that you can give, that either means they need more rapid surgical intervention, or it means they need a higher level of care. They might need, inotropes or vasopressors, and they might need invasive blood pressure monitoring. So your responsibilities are giving interventions, reviewing the results, and calling for help if they're not getting better. So, as with everything in fairly acute scenarios, we're going to do an ABCD approach. It's simple, it's easy to remember. If you do it systematically, you're not going to miss anything. And I think the most important thing is where you don't move on, for example, from A to B, if you're still worried about A, and you don't move on unless you're happy with one category, or you're giving an intervention which you're then going to review the effect of. So C, it's probably less likely you're going to be dealing with this. In this context, it means C-spine or catastrophic hemorrhage. It's more of a concern in trauma patients. A and B, in surgical patients, if their airway has gone or if their respiratory function is a problem, you're going to be calling for help immediately. If there is a surgical problem which has caused, either of those to go, you can't be dealing with that alone. So you need to call for help. What I mean by abdominal causes of respiratory dysfunction, I mean things like if a patient's been vomiting and then they've aspirated, if a patient's got a big distended obstructed abdomen, which is then splinting their diaphragm and they can't breathe properly, or even more severe things like ARDS, so acute respiratory distress syndrome in things like pancreatitis. So all throughout this, the most likely thing which you're going to be dealing with in surgical patients is the circulatory resuscitation. That's what we're going to cover in more detail. So circulatory support primarily consists of, IV fluids. It's a very, very simple treatment, but it's one that I think is done badly on the whole. Now, there's three main reasons why we give IV fluids. One is to replace losses and to restore the patient back to a normal circulating volume. One is to maintain their fluid input if they can't, maintain that themselves. And one is to correct any electrolyte abnormalities. Now, unwell surgical patients, if you think about, what they present with and the problems that they come in with, they tend to have all three of these. I think it's really important when you're prescribing fluids to always consider which one of these you're doing. And if that, if one of those is no longer the case, for example, if you started fluids because someone wasn't eating or drinking and they've resumed eating and drinking, it helps you stop at the appropriate point, because so many times you see patients have fluids prescribed and then it just goes on and on and on, and the next person gets bleeped saying, "Oh, we need some more IV fluids." You should always consider what you're trying to achieve in terms of these three, and that will prevent your patients becoming overloaded. Now, replacing losses. This is a really, really crucial subject. So what we're going to do is we're going to give crystalloid boluses whilst monitoring their volume status. That sounds really simple, but it's done really, really badly. The key things here are, I'm a big advocate of Hartmann's. It's a physiological solution. If you compare that with saline, saline has a lower pH and doesn't have any of the other electrolytes in it. Now, you'll hear, when patients have cardiac history, people, tend to err towards 250 mils. In these surgical patients, and I would give just a 500 ml bolus unless there is a reason not to. I'm all for being cautious, but also 500 is a proper bolus in these patients, and you're more likely to see an effect. Now, and what we're going to do each time we give one of these, we're going to see how things change, and we need to consider how we monitor someone's circulating volume. Now, that's things that we can observe, like their blood pressure, their pulse, and what their urine output is. And urine output is a really, really useful marker. It's a surrogate marker for cardiac output. They're things that we can, see clinically. Refill time, their the character of their pulses, their JVP. We can also look at biochemical markers. And another really useful one is lactate. Because if you think about it, we're not, when someone has a low blood pressure, we're not actually worried about their blood pressure per se. We're worried about organ perfusion and organ function. And if you think about it, urine output is a marker of organ perfusion, and urine output is a marker of organ function, and lactate is a marker of organ perfusion. And like I said, if you're giving these interventions, if you've given a proper set of boluses to no effect, then they either need more rapid surgery or they need a higher level of care. And if you're calling for sort of critical care input, the things that they will ask you is, what's the urine output? What's the lactate? What have you done already? And what is the surgical plan? In critical care, we really like urine output and we really like blood gases. Now, in terms of maintenance, so that's the second reason why we tend to give IV fluids. Everyone, I'm sitting here, every one of you will have requirements of fluids and electrolytes per day. Often in surgical patients, for one reason or another, they can't meet those requirements. So we need to do it for them parenterally. Here we've got, as I said in the last slide, we've got the compositions of, first of all, their normal plasma, and then of commonly prescribed IV fluids. And you can see saline just has, it's what it says on the tin. It's sodium chloride, a lot of them both, whereas Hartmann's is a much more balanced solution. With saline, if you give too much of it, the fact that it has so much chloride, it leads to what we call a hyperchloremic acidosis. When you give liters and liters of the things, basically the chloride has an effect on the bicarb, drives that down and worsens acidosis. Maintenance fluids is it's a really common bleep that you'll get. You'll get bleeps from nurses saying, "Our patient hasn't eaten and drinking, they need some fluids." You know, classically that will be overnight. I'd say very, very few patients need a bag of fluids overnight. You know, most of us sitting here, we won't drink anything between the hours of 10 o'clock at night and 7 o'clock in the morning, you know, and we don't need fluids. You know, we have physiological mechanisms such that, you know, to mediate that. And often, you know, the easy thing to do in response to that bleep is to say, yeah, that's fine, just, you know, get them off your back, prescribe some fluids. Whereas, you know, if you do that, you can drop their sodium, you can give them other electrolyte abnormalities, you can, you know, overload them, they can become peripherally edematous, and you'll stop them drinking. You know, people have an inherent, you know, drive to thirst, and if you just take that away from them, they're not going to drink. Okay, so we're going to do a few clinical examples. So like I said, just keep a note of your answer to this, and then there will be an answer slide where you can compare your answer to the sort of model answer, we'll say. So we've got a 56-year-old chap who's come in with left iliac fossa pain and diarrhea for 7 days, and he's been treated acute diverticulitis. He's eating and drinking as normal. His blood pressure's okay, but he's a little bit tacky. He's pyrexial. Clinically looks a little bit dry. His urine output's sort of okay. Sodium's a little bit low, potassium's a little bit low. Creatinine's okay, and his lactate is a teeny bit up. On his cross-sectional imaging, just for your interest, we've got a sigmoid colon over here. I think you can see some little outpouchings of the diverticulae here. And there's some fat stranding over here and inflammation of the bowel wall. So this is very consistent with diverticulitis. So just think about those things which I talked about. So the replacing losses, maintenance, and electrolytes. Which one of those, you know, does he need any of those three? And what would we do about those three? So just take another 30 seconds or so just to consider that, and then we'll go through it. So we can certainly see that he is dry. He's got probably slightly low circulating volume. We can see that he's tachycardic. He's got prolonged cap refill. His JVP is a little bit down, and his lactate's a bit up. So we need to do what we said. We need to give him boluses of balanced crystalloid, like Hartmann's, whilst monitoring his markers of volemic status until we get him back to a euvolemic state. Okay, that's fairly easy. As he's eating and drinking, and he's a 56-year-old man, he should be able to keep up with his own. And once we get him back to that euvolemic state and we're treating the diverticulitis, he should be able to keep up with his own maintenance requirements. However, if we then proceed to surgery, if we do a Hartmann's procedure or something, and he's made nil by mouth, we will have to give him that. In terms of his electrolytes, so he does need some correction. He's got low potassium. This probably represents just GI losses, just from the diarrhea. If we remember back to the table where we showed the composition of Hartmann's solution, that's got potassium of 5 millimoles per litre. So just getting him back to euvolemia with that fluid may well correct that potassium. However, if it doesn't, he might require some saline with some potassium added to it. In terms of hyponatremia, the way to look at hyponatremia is always what their volume status is. In this case, we've established in the first point that he's hypovolemic. Therefore, his sodium should correct itself once we bring him back to euvolemia. Okay, so another one. This is a slightly more complicated one. So we've got a 74-year-old lady who's been vomiting for 4 days, and she's not opened her bowels for several days. CT has shown small bowel dilated loops. She's hypertensive, tachycardic. She clinically looks dry. Her electrolytes are okay, and she's got an AKI, and her lactate's quite raised. this is just, this might be a scout image on the CT. Again, we've just got, centrally located, dilated, what look like small bowel loops. And again, just consider those 3 points. What's this lady going to need in terms of her restoration or replacement of her losses, her maintenance fluids, and then correction of her electrolytes? Just consider each of those just for 30 seconds. Okay. So what I would do in this scenario, again, this lady needs to be brought back to a normal circulating volume. So again, we need to give her boluses of balanced crystalloid whilst monitoring those markers until she's brought back to a euvolemic state. The maintenance fluid here is going to be the trickiest one. She's got small bowel obstruction. She's going to end up with an NG tube, which is going to drain off everything that's coming up from her stomach. She's not going to be able to keep up with her maintenance requirements. So she absolutely is going to need maintenance fluids in terms of the requirements we saw on the previous slide. However, as we said, the NG tube is going to be draining lots and lots of stuff off. So she's going to need her daily requirements plus the volume that she loses through the NG tube, plus some of the electrolytes that she loses through the NG tube. Now that's probably primarily potassium is the main one, and you also lose acid, because you're losing from your stomach. So this person may well have an alkalosis, a metabolic alkalosis, and hypokalemia if we don't replace them accordingly. So she needs normal maintenance fluids in terms of her normal requirements for her, for her weight. And then we need to replace the volume of whatever comes out of the NG tube and consider what electrolytes are going to be in there. Her electrolytes on the previous slide were okay. So we don't need to do anything at the moment, but she has got an AKI and she has just had a contrast CT scan. So she's at risk of developing contrast nephropathy and making that worse. And we need to monitor those electrolytes very, very carefully. So she's in danger of going hyperkalemic with an AKI that might get worse. And because she's losing so much potassium, she might be at risk of going hypokalemic. So we need to monitor those really, really carefully in this lady. A quick note on hemorrhage and blood products. It says, obviously, the need for major hemorrhage there. The second, I think the second that you think to yourself, should I be putting out the major hemorrhage protocol? That is normally when you should put out the major hemorrhage protocol. It's something, it will get you 4 units of O-neg straight away. And it will get FFP defrosting. It will get platelets out of the fridge. You can always step it down. It's a bit like putting out a peri-arrest call. It might be that some things aren't needed and you step it down, but you're better off having put it out and got those products ready for that resuscitative phase than you are, doing it too late and the patient being far, far behind on their fluid resuscitation. For most things, you just need to make sure that they have 2 valid grouping saves sent to the lab. That's just something that you just need on your little checklist in your head just to tick off. And then you need to just consider what operation they're having. Some operations like a lap appendix, you very rarely need any blood products. Laparotomies will often need more than 4 units. Oh, and if you are putting out a major hemorrhage protocol, you're very likely going to be putting out a peri-arrest call too, because I don't think I've ever heard of anyone trying to manage a major hemorrhage on their own. A quick note on just the investigations that need to be completed once you've adequately resuscitated that patient. This isn't anything too complicated, but these are all things that you should consider just to tick things off such that you know that they're done and they're out of the way, and you can focus on the patient's further management. So everyone, these will likely have already been done by A&E, but really, really simple things. Just make sure they're done, and you're better off having reviewed them early. You need an ECG. Anaesthetists will want to see it. And these patients, arrhythmia is a big problem, and it often gets overlooked because, there's a patient with a surgical problem in front of you. They've got low blood pressure. Arrhythmias can be overlooked, especially when they're tacky. You might not feel that it's irregular, especially the bowel obstruction and the laparotomy patients. They tend to go into AF immediately post-operatively. And the things you can do to optimize that is really good volume resuscitation, as we talked about, and optimization of their electrolytes, particularly with the potassium and magnesium. Just radiographic, most people will get a chest x-ray when they come in, whether that's just to look to investigate any respiratory problems or air under the diaphragm. But again, anaesthetists will probably want to see it. And cultures. You've got a real opportunity when you see a patient for the first time to take a really good set of cultures, which will make your life so much easier when you're then taking care of them on the ward a week later and people have started antibiotics and we don't know what we're treating. Because if you don't take a good set of cultures before starting antibiotics, you make your life 10 times as difficult when you then have to try and stop the antibiotics, because your senior will probably just send you down to talk to microbiology, and they probably won't be very happy. So we're happy that we have resuscitated the patient from a circulatory point of view. We've completed those initial investigations. By this point, your patient has come in with something, most likely, vomiting, abdominal pain. We need to make sure those symptoms are taken care of, not only just from an ethical point of view, but also just to improve that patient's experience. So analgesia, again, so important, but so easily forgotten about, again, especially when you've got an unwell patient in front of you. Can be a tricky one because, again, patients often can't take anything by mouth. Things that you can do which are really, really effective. So I think just every surgical patient, just give them regular paracetamol. Route depends on, are they vomiting? Have they got bowel obstruction? And then just a dose will just depend on their weight. Every patient, I think, should probably have a PRN opiate. Now, again, the route depends on what we talked about. The actual agent will depend on what their renal function is. And if they're in a lot of pain, they may well need a regular opiate as well as a PRN opiate. And specific analgesia, that's things like lidocaine patches for rib fractures. That's things like diclofenac for renal colic. Just the simple things that you can do. Now, if that doesn't quite cut it, there are more advanced things that we can do. And you won't be doing these. But these are things that you will ask other people for help with to get these done. Now, PCA, that's what we call a patient-controlled analgesia. Now, this is, it's basically an infusion pump, normally with an opiate in it, and it's controlled by a little button that the patient holds. And whenever they press a button, they give it gives a little IV bolus or even subcut bolus of opiate. Patients can't just narcose themselves because it has a lockout time, normally of about 5 minutes, such that they can't give themselves more than one bolus in 5 minutes. And if patients do narcose themselves, then they're too sleepy to press the button. And yeah, so it's a really nice way of controlling pain, especially post-operatively when they've had a big surgery. So that's obviously systemic analgesia. In terms of regional stuff, for hip fractures, something that's widely utilized is fascia iliaca block. So that's something, it's basically a needle with normally just a local anesthetic. It goes down a few planes of fascia in the inguinal region and injected around the nerves supplying that joint. Gives really effective pain relief. And then sometimes even in trauma patients, especially epidurals, are something that again are really useful. So PCAs and epidurals, that will probably be the anaesthetists sorting that out for you in terms of who to contact. And fascia iliaca block A&E will normally do that in patients with hip fractures. Now, antiemetics, commonly in surgery, patients will just be prescribed cyclizine and ondansetron. That's fine. they're simple. They don't really interact with other things. They do tend to work. They have some benefit. And any benefit that we can give them is really important because, again, we want to make the patients feel better. And if we stop them vomiting, we reduce the risk of them aspirating, and we reduce the amount of volume and electrolytes they're losing from that route. So cyclizine on ondansetron, like I say, they do work, but they're not always effective. They're fairly narrow spectrum. Cyclizine is a histaminergic effect. Ondansetron is serotonergic. If we do need NG drainage to stop vomiting, that is not a very nice thing to do to put it in, but actually to stop them vomiting, can actually overall be of symptomatic benefit. Second line tend to be in these patients tend to be things like haloperidol or levomepromazine, so low dose antipsychotics, but you have to watch out for sort of extrapyramidal side effects. And in these cases, your pharmacists are some of the best allies that you'll have. They're really, really useful in talking you through the action and the potential interactions of these medications. So we're going to do another clinical example. So we've got a 38-year-old chap. He's got gallstones. He's quite a big chap and he drinks quite a lot. He's had epigastric pain and vomiting. Bloods show his amylase is over 5,000 and he's got rising inflammatory markers and he's got an AKI. So this chap very likely got pancreatitis. He's got a few reasons why he might have pancreatitis, but how are we going to manage this chap's symptoms, particularly with regard to his pain, first of all, and then his vomiting? So again, just take 30 seconds and just consider that. Okay, so taking those in turn. So his pain, like we said, he's going to need regular paracetamol, IV. He doesn't need a reduced dose because, like I said, he's probably quite a big chap. This guy, it sounds like his pain, he's going to need a regular and a PRN, as required opiate. It's going to be oxycodone because he's got an EGFR. In terms of specifics, what I'd probably start him on is something like 2.5 regularly QDS plus another 2.5 as he requires it. And that can always be titrated up and down. In terms of antiemetics, ondansetron is okay given you've got no arrhythmias or electrolyte disturbances. Cyclizine is also fine. Actually, another thing to consider here is metoclopramide. Now, pancreatitis patients, they tend to vomit because they have a sort of obstructed duodenum from all the sort of retroperitoneal inflammation, and things just can't get round the duodenum from the stomach. The metoclopramide, it has a prokinetic effect. It pushes things through that section of the GI tract, and it's really, really helpful in terms of relieving that sort of partial obstruction. Given that we're probably going to be starting him on a regular opioid, he's going to need some laxatives. Again, and if he's going to take those laxatives by mouth, we need to get his vomiting under control. If all of that, if the regular plus PRN opiate doesn't work, he's probably going to need a PCA. And some of you, again, the textbooks do say that opiates, I think particularly morphine, can worsen the sort of spasm at the sphincter of body. Particularly, as we mentioned, this chap's got gallstones. So if that is the etiology, in theory, it could make it worse. But I've never seen it personally. And you have to balance that against the risk of, if we don't control this guy's pain, he's not going to breathe properly. He's going to, collapse as the base of his lungs. He's going to get hospital-acquired pneumonia. He's not going to want to eat and drink. This chap is going to be far worse off if we don't control his pain. So, and if you give opiates and they do worsen it, we can always stop. But I find that pancreatitis patients often really, really benefit from good multimodal, but including opiate analgesia. So we've resuscitated the patient. we've completed the investigations and we've made the patient feel a bit better. And we've established that our seniors think that the patient has to go to theatre to fix whatever's happened. In terms of how much benefit we can give from this patient, we need to know, how risky is it going to be to take this guy to theatre? Now, this will involve taking the patient's past history. Again, your responsibilities here is you need to have a really good understanding of the patient's medical history, surgical history, and their functional background. A&E will probably do that to an extent, but often they're under a lot of pressure to see a lot of patients very quickly, and often this isn't the most important thing on their job jobs list. So you probably will need to delve into this in a little bit more detail. And functional status, what I mean by that is it's not it's more of a patient, how the patient can function, or how much exactly they can do. It includes things like independence, exercise tolerance, and it's a really good way of making sure that you and the patient are on the same page with how much they actually do. So on the screen, you've got two scoring systems. There's a lot of scoring systems thrown around in surgery and perioperative care. On the left, we've got ASA, which is it's basically a shorthand for just anaesthetic risk. ASA1 is probably most of the people, young people, fit and healthy. ASA2 is mild disease, something like asthma. ASA4 is once you start getting to people with bad COPD who end up in hospital a couple of times a year. On the right, you've got a P-possum score, which is used to sort of predict intraoperative mortality in laparotomy patients. Now, you're going to hear a lot of these scores thrown around, but I don't think you'll be expected to calculate these. Again, your responsibility here is just to have a good understanding of the patient's histories, i.e. you're going to be the one establishing, all the information that gets inputted into these scores. Okay, so you need to, I think they're a good, they're a useful tool for your kind of level to understand that the things that we want to know in order to, do the most amount of benefit through surgical intervention for this patient. So, again, you're not going to be the one anesthetizing the patient, so it's not your role to do an anesthetic assessment. You don't have to start worrying about, how fat the patient's neck is or how short the patient's neck is, and things like that. Again, this is just what we covered. So you need to know their functional status. That includes of tangible questions, their medical history, and their surgical history. Without this, if you don't know, exactly what the patient's history is, you don't know how risky the operation can be, you can't let the patient know that, and therefore they can't give informed consent. So this is really, really key in order to actually, level with the patient and, set their expectations in terms of the outcome from surgery. When this gets difficult is when the patient's moribund, when the patient's confused, and you probably will be calling the patient's family, carers, to find this out and looking through sort of GP records, because it's not, you can't just say, patient's confused, can't give me any history. If you're going to give the patient a surgical intervention, you need to know these things, and you need to be quite sort of resourceful in sort of how you go about finding these things out. Also, there's just as a bit more background to this, there's just research done many years ago, which basically identified 3 groups of patients which tended to die either intraoperatively or postoperatively. The first group is those who have severe co-morbidities to begin with. The second group is those who have severe surgical problems. And the third group is those who have complications. And we can predict those two groups from taking a really, really good history, okay, thereby predicting, the risk of mortality, and that can be conveyed to the patient because the patient needs to know that. So functional status. You will often hear, despite these being not very useful questions, you will hear them asked. These questions are closed questions, and they're questions that patients, they can interpret them in different ways, and they will just default to saying yes. If you just ask, are you independent? Patients, it takes a lot for a patient to go, actually, no. And actually independence, you can mean totally different things if you're a doctor or a patient. Better questions to establish a patient's functional status. Things like, how much help do you have around that? If the patient says, I haven't left the house in weeks, someone else does my shopping, it's a bit of an effort to get from the bedroom to the living room, that's a really, really crucial bit of information. Things like, can you wash and dress yourself? Both you and the patient, exactly what, each other means when you ask that. There's very much less room for sort of subjectivity or ambiguity there. In terms of exercise tolerance, put things in, distances or units that patients understand. So a flight of stairs, can you get around the supermarket? Can you walk to the pub? They're things that both you and the patient know. That's a much more useful question than, are you fit and well? Because patients will just say yes, even if they're very much not. This is something called a clinical frailty scale. It's quite widely used. Basically, where your patient is on that, it's very useful because, again, it's so widely used that if you can put your patient somewhere on that, say, let's say they're a 4, that immediately sort of standardizes across different kind of specialties, and it makes sure, between specialties, we know what we're talking about. Similarly, with medical history, a not very useful question is, do you have any medical problems? Again, closed question, patients will forget things. They'll just say no. Patients often, they won't see their problems as medical, even though we do. Things like, hypertension, diabetes, patients will just, choose to omit those. Also, if you say, do you take any medications? Some patients just won't take the medications that they're prescribed, and so they'll just say no. So again, much more useful questions is, do you have to see your GP anything about regularly? How many times have you been in hospital in the last 12 months? And obviously you then go on to sort of explore that further. Ask specifically about these things like hypertension, diabetes, and COPD. And then, do you have any medications prescribed? So that way, patients might think to actually, oh yeah, I probably should mention that blood pressure tablet. This is really important as well. So if, just a bit more background. So when you're anesthetizing a patient, you're changing their whole physiology. When you induce anesthesia, you're giving them a load of drugs. You're giving them a sedative, a hypnotic, a muscle relaxant, various things which will tank their blood pressure. You're then doing a bag mask. You're bagging them. You're giving positive intrathoracic pressure. You're reducing their venous return to their heart. Again, you're dropping their blood pressure. And you're maintaining anesthesia with things that irritate the airways and can make people cough. So if you don't have a good cardiorespiratory reserve, or, and especially if you don't know that the patient doesn't have a good cardiorespiratory reserve, that patient is at a big risk of arresting when you start to induce anesthesia. So that's why this is so important. And then briefly, again, this is probably the bit that you already know about, but you need to know their surgical history, and specifically, what operations and how urgent, what exactly did they have. Patients don't tend to be that familiar with things like spinal or local, things like that. So either I was put to sleep, or I had a tube down my throat, or I had a needle in the back, kind of things. any complications, particularly with infections, critical care admissions, we especially want to know about, or other surgical complications, and any follow-ups that have taken place. So we found out a little bit about our patient. We've sort of determined what their sort of operative risk might be. In order for us to proceed with the surgery, we then need to communicate that to the patient, and we need to have adequate consent. Now, again, your responsibilities here, you need to have a good idea of the patient's capacity. You're not going to be the ones taking consent. Generally, you should only take consent for procedures you know how to do, but you may be the one completing the consent form if you have witnessed the consent conversation, for example, with your registrar or consultant. If the patient doesn't have capacity or doesn't seem to have capacity, you need to take steps to optimize that. And if the patient does not have capacity, you need to try and do a bit more digging to try and find the sources and the elements to guide what is going to be in this patient's best interests. We'll cover this in a bit more detail. So like I said, you should only really be consenting patients for procedures you know how to do. It used to be that, for example, the orthopedic SHO would go around in the morning and consent all the knee replacements and ankles to be done that morning. However, there's been a sort of trend towards the seniors only doing this. Consent to be valid, it needs to be voluntary. Patients can't be forced or coerced. It's a classic SJT question where a patient and his wife comes to you, and the man looks very sheepish, but the wife asks for him to have a vasectomy. It can't be coerced or anything like that. It has to be properly informed, and that's it's a simple term, but it's slightly more complex when we actually consider what it means. So they have to know what it is you're going to do, how you're going to do it, what's the intended benefits, and what could go wrong. And in terms of what could go wrong, they need to know what commonly goes wrong and what could be potentially serious if it did go wrong. And all of these things need to be documented in writing, and you may be the one doing that. And finally, the person has to have capacity. Just coming back to the serious possible side effects, you need to consider on a patient-by-patient basis. For example, if a patient only has one eye and you're doing a cataract operation, the risk of blindness, although it's very low, it could be extremely, much more significant to that patient than a patient with two eyes. Or, for example, if you're doing a thyroidectomy and there's a risk of laryngeal nerve injury in a patient who is a singer, that's their livelihood, that's their career, that's much more serious than someone who's not a singer. So I thought I'd just put this in context. This is just the consent form from my old trust. This is consent form 1. This is a consent form that you may be filling out, having witnessed the consent conversation. Again, so just patient demographics up here. Again, so this just goes in line with what was on the last slide. So what are you planning on doing? What are the intended benefits? So we've got the common and the serious risks of this. Ooh, let's just go back. Again, are any other procedures going to be happening? What type of anesthesia? And then you're going to, or your senior is going to sign, print, date, and their job title. But you may be the one witnessing the conversation. And as the registrar, for example, explains all these, you need to write down exactly what they've said, what the intended benefits are, and the risks that they have discussed, because this is a medical legal document. So it's fairly simple. If the patient does have capacity, they clearly, are able to make decisions about their own health. It gets slightly more complicated when patients, when we don't think they have capacity. So just a little bit. This comes from the Mental Capacity Act in 2005. Just because patients, don't go along with our way of thinking, they're wanting to do something which we would consider unwise. It doesn't mean that they don't have capacity. That's one of the principles in that act. Capacity is decision specific. patients with, delirium or learning difficulties, they may well have the capacity to know what they want for breakfast, but they may not have the capacity to know whether they would want to undergo a very risky but potentially life-saving operation. You also need to consider, is their capacity going to recover, and can decisions be delayed until that happens? Also, have you done the simple things to try and optimize the capacity? Have you given your old patients their glasses back? Have you given them their hearing aids? Have you, if they don't speak English, have you ordered a translator? That kind of thing. Have you spoken to the carers? So even after steps have been taken to try and optimize their capacity, if it still seems that they don't have capacity, we need to formally assess this, and that's 2 steps. Do they have a reason why that they've got this cognitive impairment? And secondly, do they have impaired ability to do only one of retain, understand, weigh, or communicate their decision with respect to that question? In the event that they do not have capacity, everyone involved in their care needs to act in their best interests. Again, it sounds very simple, but it's actually quite complex when we get further into it. There is a long-winded definition as to what best interests are, but the things that you need to do is have a look into these things to guide what exactly is going to be in this patient's best interests. And the helpful things are, do they have advanced decisions? Have they written down in a legal document, I absolutely categorically do not want this to happen to me in these circumstances? Does the patient have a lasting power of attorney for health, who's been nominated to be the person to guide those decisions? And in the absence of those things, are the family or next of kin able to tell you, what would their previous wishes have been? What are their values? What's important to them? Again, just because you have a lasting power of attorney, it doesn't mean that the lasting power of attorney makes the final decision. Even if you are a lasting power of attorney for someone, you still have to act in their best interests. It's just all of these things, they're tools to help the healthcare team and everyone looking after them guide what exactly is in their best interests. Again, this is the equivalent consent form for those who don't have capacity. You'll see a lot of the same phrases. So again, plan procedure. And there's a little bit more to it this time because you need to show that you've acted in accordance with the Mental Capacity Act. You've confirmed that they have an inability to do one of these 4 things. How you've reached those conclusions. You need to show that you've considered their best interests and why this decision can't wait until they regain capacity. And then this is the second page to it. This is where you would consider involving their next of kin or their family. If that's just a phone conversation, there's a little thing down here. Has this been discussed? And if you write yes, that gives more weight to, you've really considered what is going to be best for this patient, or if the patient is there to discuss it, they can sign their name there. Attorney or deputy, again, that's lasting power of attorney, and this is your signature. And you really need to fill these out, properly. Again, this is a medical legal document. Just highlighting the important bits here. Okay, so patient is going to go to theatre. They're going to have surgical intervention. Your senior is very happy. They get some time in theatre. However, increasingly the patients that we get through are old. They have comorbidities, and these comorbidities don't go away during the perioperative period. If anything, they need more intensive scrutiny during this perioperative period. So what your responsibilities are likely going to be is, on a practical point of view, you're going to be taking ownership of that patient's normal medications, reviewing them, continuing those that are appropriate to do so, and making changes as appropriate. You need to make, a perioperative plan for their comorbidities. And this is something that you probably will have received limited help from your surgical seniors regarding this. If you're unsure, it's again going to be your responsibility to ask the appropriate person. For example, if the patient has epilepsy, you need to convert to IV. You can need to ask pharmacy. If you get stuck with their diabetes, there's normally a diabetes specialist nurses and that sort of thing. So it's taking ownership of those, making a plan, and then calling the right person for help if you do need help with these. So diabetes is probably the most common one. And the key is finding out really thoroughly exactly, it sounds stupid, but that it does happen. And in that, there's confusion as to whether a patient is type 1 or type 2. You need to know exactly what they take and when. Are they on oral meds? If they are they ones which can give you hypoglycemia, such as gliclazide? Are they on insulin? Which type? How much? So it's really, really key that you know exactly what their regime is. So with respect to diabetes around sort of the perioperative region, if the patient is eating and drinking as normal, just give them what they would normally do. Especially type 1 diabetes, the patients probably are far better at managing their own diabetes as long as they're in a physiologically normal state than you are. So if the patient's eating and drinking normally, just give them whatever they would normally take. It's really, really simple. If patients are going to be nil by mouth just for a short period, you just need to omit the things which are potentially going to drop their glucose. For example, things like gliclazide or short-acting insulin. If patients are not going to be eating and drinking for an extended period, the best way of managing this is a variable rate insulin infusion. Now, what this is, again, it's an infusion pump with normally some act-rapid insulin inside it. And basically, the speed at which the insulin infusion goes is adjusted every hour or 2 hours, depending on what the patient's blood sugar is doing. So really, it's a sort of external pancreas, if that makes sense. Except we're controlling it. We're measuring don't worry, you won't be doing this. The nurses will be doing this. They'll measure the patient's blood glucose. They'll document it. They'll go to the chart. They'll see what the glucose is, and there will be next to it a rate for the insulin infusion to go at. So really what we're doing is we're mimicking their normal sort of insulin requirements. And it's a really, really safe and effective way of managing diabetes when patients, when their oral intake is sort of all over the place or just non-existent. So I'm going to do a few clinical examples. So I've got a 72-year-old lady. She's obese. She's got type 2 diabetes. She's hypothyroid. She's come in for a thyroidectomy. And we've told her to be nil by mouth from midnight the evening before surgery. Now you're let's say the ENT F1, and you've got this patient coming in a couple of days' time. What are you going to tell her to do with her diabetes? Now, hopefully the first question that comes to your mind should be, what exactly does she take for her diabetes? So she tells you she takes this. So what are we going to tell her to do with these 2 medications over the perioperative course? And again, just take 30 seconds and just consider that. So also consider, as well as telling the patient what to do with her medications, when this patient lands on the ward afterwards, just think about who you might like to sort of make aware of this and some instructions that you might like to give to the ward with relation to this lady's diabetes. So again, first thing you should ask is, what is she on for her diabetes? We're given that. We need to consider which of those 2 agents can potentially be hypoglycemic. In this case, the gliclazide can drop your sugar. Metformin doesn't really give you hypoglycemia. It sensitizes you to insulin, but it can't really drop your blood sugar. So she should definitely omit her glycoside because she's not going to be having breakfast that morning. Ideally, she should probably hold her metformin as well. In reality, it probably doesn't make too much difference, but there are all sorts of historical concerns about lactic acidosis, metabolic acidosis. So she should probably hold them both, but the far more important one is the glycoside. As we said, once she is eating and drinking normally, she can go straight back on them. With a thyroidectomy, that's probably going to be by the evening dose. But if she has a complication, if she can't swallow, until she's got some nutrition into her, we need to omit those. And this was the second bit I was talking about. In order for this to be safe, the ward that's accepting her, the nurses need to know that she is diabetic. If you find an unconscious patient and they're diabetic, the first thing that you think of is a hypo, and you can treat that much more easily than if you don't even know they're diabetic. On their drug chart, they should probably have PRNs, so hypo, things like glucogel, 20% dextrose, or even IM glucagon. And in terms of hyperglycemia, that's normally just 4 to 6 units of act-rapid insulin. So those are things I would consider with respect to managing this lady's sort of diabetes in the perioperative period. So the second one, so this is a 54-year-old lady with type 1 diabetes this time, and she gets a lot of UTIs. She's come in with flank pain, vomiting, fevers, and we think she's got pyelonephritis. We're treating her with IV antibiotics, but she is still vomiting. So how are we going to manage this lady's diabetes? Let's say, for the sake of argument, that it doesn't look like she's going to stop vomiting anytime soon. So again, the first thing you should ask is, what exactly is she on for her diabetes? And she tells you this. So just consider, what are we going to do with her diabetes? How are we going to communicate to the ward about her diabetes? And what just in case medications are we going to have on a drug chart? So the first thing I would want to do with this lady is, given that she has type 1 diabetes and has been vomiting a lot and is a bit unwell, I want to make sure that she's not in DKA. If she's hyperglycemic, if her ketones are high and she's acidotic from a circulatory perspective, then she needs medical treatment of that. She needs volume resuscitation first, and then she needs a fixed rate insulin infusion to drive down those ketones and to sort of mediate that acidosis. After we've done that, again, we want to know exactly what her regime is. In this case, I believe it was just basal bolus. So the concept of that is, she's got just once an evening or once a morning long-acting insulin, and then she takes short-acting insulin on top of that to mimic, the spikes in insulin that we have when we eat 3 meals a day. Again, like we said, she's not going to stop vomiting anytime soon. Her oral intake is going to be very variable. So she needs probably a variable rate insulin infusion. So we need to monitor her blood sugar and then give her an appropriate rate of insulin infusion to monitor that blood sugar. You can, it probably won't make any difference, to the patient's management to begin with, but you can continue with this lady her long-acting insulin alongside the variable rate insulin. It'll just mean that the sugars will tend to be a bit lower, and she'll need slightly less of the act-rapid infusion. But again, you won't do any harm. As long as they're on the variable rate insulin, you won't do any harm by omitting the long-acting insulin. Again, if let's say that the patient, was okay, they were managing to eat a little bit. Again, this lady has probably had type 1 diabetes for 40 years. She has probably been unwell at least a couple of times during those. If she is confident with, she knows the right amount of insulin to give herself, she can probably do it better than we can. So if she's happy to manage that, just let her. In order to get this patient eating again, she needs analgesia. She had flank pain, and she needs antiemetics, which we talked about. Again, the nursing staff, they very likely will be, but they need to be aware that she is diabetic, and they need to have the variable rate insulin prescribed and signed and make sure they're happy with it. And again, they need PRNs, both for hyper and hypoglycemia. So, onto epilepsy. This is quite a scary one because everyone gets really, really frightened that patients are going to have seizures, and that's going to set them back and lead to complications. Again, the key is knowing exactly what their regime is in terms of doses and timings. And the things to consider are, have they been taking their anti-epileptics, i.e., are they at risk of having a seizure, in front of you? Can we prove that? Can we measure levels, things like valproate, phenytoin, we can measure levels of. By what route, what route is available to us? IV is fairly, robust. We can give things like levetiracetam, we can give phenytoin and valproate or IV. And we're probably going to be starting, they're coming to hospital, we're probably going to be starting them on new medications. And you need to be careful that there are no interactions. And a key one that you will come across is an interaction between meropenem and valproate. If you put a patient on meropenem, it's a fairly common antibiotic for hospital-acquired pneumonia and sepsis of unknown source. That will decrease the patient's valproate levels to almost zero. And patients will seize because of this. So it's one that you need to consider. And again, the people to ask about this are pharmacists, because they're really, really on it with this sort of thing, and they can really, really help you. Another common one that you'll see, again, with an aging population, a lot of really frail patients, is Parkinson's. This is especially difficult because Parkinson's patients, they have problems with swallowing, especially when they're unwell from a surgical perspective, and they're very, very vulnerable to falls and delirium. And it's something that you really, really need to get right. Parkinson's, again, you need to know exactly what they take and when they take it. And you often will receive a little bit of pushback from the ward about that, because often they'll be on something like 6 times a day co-beneldopa, and the patient will take them at slightly odd times, but that's what works for them. And you need to reinforce to the nursing staff, although that's not when they usually do their drug rounds, that is when a patient needs to have their Parkinson's meds, because that's how we're going to best manage it. If things get a bit tricky, if they if things are easy and they can swallow safely and they're not delirious, you give them exactly what they would normally take. And if they can't remember it, you need to ask their carers or their family exactly what they take and when. If patients are unable to swallow or they're too delirious, then a really easy thing to do. Most trusts will have specific guidelines in terms of converting common Parkinson's therapy, such as co-beneldopa or co-carbidopa, into an equivalent amount of retigotine patch. Now, retigotine is it's a little patch that goes through the skin, and it's a really reliable and effective way of getting their Parkinson's med into them. Because if you don't, then patients will end up just acutely Parkinsonian, really stiff, often really delirious, and that's really not a nice state to be in. So those are the main sections that I've covered. This is just a few more little bits which they're not quite big enough to warrant their own section, but you do need to think about for every single patient. And those are VT and antibiotic prophylaxis and EPAs. So just a quick note about VT prophylaxis. In terms of what you choose, it depends on their renal function, how worried you are about clotting and bleeding. Generally, patients will get, pretty much all surgical patients will get a low molecular weight heparin, unless you're really, really worried about bleeding. In terms of what dose you give, that is specific to the medical specialty. The general surgery patients tend to get slightly less than the orthopedic patients, for example. in terms of when to stop, or when to start and stop. Before surgery, you tend to leave off 1 or 2 doses, and then when to restart it again. That again is specific to the surgical specialty. For example, patients who've had prostate or bladder resection, they tend to just not have low molecular weight heparin for the rest of the admission, and they'll require on sort of mechanical prophylaxis and compression stockings. And it's not just a hospital thing. VT prophylaxis may well need to be given after discharge, especially patients who've had big abdominal cancer surgeries. They tend to need 6 weeks of low molecular weight heparin. And even patients with hip replacements tend to get some rivaroxaban, the DOAC, after discharge. And again, if you're not sure, pharmacists are so helpful with these things. A quick note about antibiotic prophylaxis. Again, it's forgotten about quite a lot. Your trust will have specific guidance, but just common things like putting a catheter in, if there's any high risk, if there's any reason which might make that procedure more high risk, for example, the patient's recently had an operation or has had a UTI or has sort of a structural deformity of the urological tracts, that warrants prophylaxis. And it's really evidence-based that giving them a shot of, it's usually gentamicin, IV or IM, significantly reduces the the complication of infection following those procedures. So it's often forgotten about, but just consider whether simple things warrant prophylaxis. And as Lawrence said, one of my special interests is in-hospital resuscitation. I'd like to make the point, this isn't just me being, working in critical care, sitting up in my, ivory tower. It's a mandatory thing. Every patient who comes in has an unplanned admission, with the exception of peds, obstetrics, and that's it, needs to have an EPARS decision documented, normally within 12 hours. Some hospitals it's 24 hours. And what we mean by EPARS, escalation plan resuscitation status. So broadly, starting from right from the top, you'd go, the patient is for everything. The patient is for CPR. The next one down would be do not attempt resuscitation, but the patient would be for intensive care, multi-organ support. The next one down would likely be for ward-based care and DNAR. After that, it would be for best supportive care and DNAR. And after that, it would likely be palliative care and DNAR. It's not a patient decision at the end of the day. There's a lot of misconception that it is, a patient choice and patients can choose to be resuscitated, which just isn't true. It's the same as any other treatment which we give. A patient can't walk into A&E and demand, treatment which will give them no benefit, and the same is true for CPR. Okay. And there's been a lot of really high-profile cases surrounding this, where patients and families have gotten really upset, and some of these cases have ended up in like the High Court. And if you look at these cases, the common theme between them is that there wasn't good, timely communication between the healthcare team and the patient and their families. So you do need to have these discussions. At the end of the day, it's probably not going to be your responsibility to make the decision. It's going to be probably your senior who needs to document this decision. But if you're comfortable to do so, and in having these discussions, you will really help your seniors, okay? Because I'm not trying to make a point about all surgeons, but a lot of the time surgical seniors are reluctant to have these conversations. But if you're comfortable in doing so and you can let them know the outcome, you'll really help. And I think these conversations, they're scary the first time you have them, don't get me wrong, but you can make things a lot easier for yourself by just normalizing it, by just saying what I've said to you. You say, this is a mandatory decision which we have to make for all patients that come into the hospital. And in normalizing it in that way, patients won't, run for the hills or or anything like that when you have that discussion with them. I think it's, often patients just won't have this, documented in some hospitals, which I think is really, really unfair, because, the person who's not documented that is more often, for example, a surgical registrar or consultant. And realistically, it's not going to be them who's doing the CPR, because that's been commenced because there is no decision. So it's not fair on you guys. So it is something that you should bug your seniors about. They won't thank you for it, but you won't thank them if you end up doing a CPR on a 90-year-old man because there hasn't been a decision made about this. That's about everything I wanted to cover. Sorry, it ended on a slightly slightly sinister note, but it's now time for everyone's favorite thing, that's feedback. So we've got a QR code up here, which will hopefully take you to, it's a very, very quick little form. Please be honest. I hope that this was useful. I've tried to make it as pragmatic as possible and to be as useful for your guys' level as it can be, and to just hopefully give you that approach and prepare you for that. My worst shift as a doctor to date still was my first on-call shift in surgery, for all of the reasons which I talked about in the first few slides. And hopefully I've tried to address some of the reasons behind why that shifts were so bad in this presentation. So I want to try and make it as useful as possible. So please do, be honest with the feedback. And thank you all for attending. And thank you to Lawrence and the rest of the National Surgical Teaching Society for setting up this platform.
Okay, thank you so much, Nick. That was an absolutely fantastic talk. Guys, so if you just fill out that feedback form really quickly, and then we'll have a time to go through a couple of questions. Thank you all for sticking around. I know we've run slightly over, so sorry about that. So yeah, hopefully people have had a chance to go through that really quick feedback form. And if we don't have time for questions, then he's made his email address available here. So feel free to send him drop in a line just with your question, and he'll try and get a reply to you as soon as possible. Okay, so Nick, if would you like to go back to the QR code, and then people could
oh yeah, my bad,
listen to a couple of questions as well while they're okay. So the first question is, so going back to the pancreatitis patient, so metoclopramide is contraindicated in obstruction. Would you not avoid it since you don't know the extent of the obstruction at presentation?
Yeah, that's a really good question. So it's contraindicated in mechanical bowel obstruction. I would agree. The obstruction here isn't complete. It's not a complete obstruction. It's more just, if you imagine the the pancreas, the big inflamed pancreas, sort of pressing on the duodenum, and things just not getting round that corner, and often just the prokinetic effect of the metoclopramide just pushing it round that corner can really, really help. So yeah, although you do need to, if someone has a genuine obstruction like a bowel obstruction, yes, you do need to be careful. But in a sort of it's more of a sort of an extrinsic slight compression, it is utilized, and it can be utilized to good effect.
Okay, great. Another question. So with consent only being undertaken by those who can do the procedure, would we as F1s ever be asked to complete this? And if you are asked to complete it, how would you go about saying no to a senior, for example?
No, that's a really, really good question. It's the sort of question which might form the basis of like an SJT type question. For example, your registrar asks you to take consent for this procedure you've never done. In that scenario, so I doubt you would ever be asked to do that. But if you were, how I would approach it is I would explain to whoever's asked me to do it that I've never done that procedure. I'm very happy to give it a go, as long as they're willing to, come along to see that you're doing it correctly, that you're explaining all the right things. You know, if they're at the end of the day, if they're going to be the one doing the procedure, it's their responsibility to make sure that the consent is taken appropriately. So unless they're willing to see that you've done the consent properly, you know, I wouldn't do it. I'd say, you know, I'd very, you know, politely and respectfully, I'd say, you know, I've never done that procedure. I've never taken consent for that before. I don't know exactly, you know, how to explain the intended benefits and the serious and commonly occurring risks. I'm sorry, I'm not happy to, you know, take that consent.
That sounds like a great way to do it. So another question, what volume per day of extra maintenance fluids are needed if an NG is in place?
Yeah, good question. So it depends how much exactly is coming out of the NG. You know, the most difficult thing about these patients with bowel obstruction is what we call the fluid balance. Now, patients will probably have a fluid balance chart, whether that is a physical chart or it's on a computer. So that will take into account all the fluid that they've had, whether that be, you know, predominantly that will be IV, medications, things like that. And then the fluid outputs, that'll be that urine output and the NG output and things like that. You need to be measuring how much comes out of the NG every couple of hours and try and match that with how much fluid you're giving them, plus their maintenance that they already have from just being a metabolically active human.
Right, okay. I hope that answers the question for whoever asked it. So penultimate question. So as the junior, are you expected to start the patient on the variable insulin sliding scale, or would the nurses start this?
You'd be expected to prescribe it. You wouldn't be the one drawing up the solution with insulin and dextrose. So what you'd have to do is you'd prescribe. However it's done, it'll likely be on a chart or on the computer. You'll prescribe the variable rate insulin infusion. You'll give CBG targets, which are normally between 6 and 12. And you'll prescribe the fluid to run alongside it, which is normally a balanced solution of, it's normally half dextrose saline with potassium added as well. So you'll be doing the prescribing, but you won't be the one, administering it or monitoring the patient's glucose. The nurses will do that.
Okay, cool. And then just a last question. So from your perspective, working in anesthetics, what qualities are important to be a good surgeon?
That's a really good question. So I would say good working relationships with other specialties, be that critical care, anesthetics, medics. I'd say communication with patients, families, and again, your team is really, really crucial. A lot of the reason why people find surgery is such a daunting specialty when they first start is because often they can just feel a bit abandoned out on the wards because people are in theatre or whatever. So I think you need to make yourself available, and accessible. And just I think taking a bit of time to get to know the patients and having a good overview, because only by taking that sort of good overall view of the patient can you actually appreciate, how much benefit can we give to this patient.
I think that's a really good answer. Something we can hopefully all try and do in the future. Okay, I think that's all we've got time for today. If you haven't already, please do the feedback. Just scan the QR code, or link is in the chat, I believe. And thank you all, everyone who's stuck it this far.
Sorry it ran over.
Yeah, and we'll see you next week. Yeah, thank you very much, guys. And thank you, Nick.
Cool. Thank you.